Good afternoon, everyone. It's Chris Mastrangelo with Harmony Healthcare International. Today is the first of 8 Thoughtful Thursdays, and we are going to be discussing the requirements of participation, specifically the training requirements. And these training requirements, there are 7 of them. Today, week 1, I'm going to give you an overview. And I know that people are still logging on, and that's why I was delaying. So we will go through this, and then every subsequent week, we'll have a comprehensive review of the training requirements and a training that should be applicable so that you can use. So let's see, this is one of 8 weeks, and thanks for joining us. This is a variant from the Freaky Friday, and I haven't seen you guys in a while, so we're getting back on track with that. The whole concept of the requirements of participation is that, and again, for administrators on the webinar, you know, this is what you were trained to do. In other words, this is very natural for you because you took the test and you know that the rules of engagement. But for many other people, they may not be aware that because your facility, because your nursing home receives funding from CMS, Centers for Medicare and Medicaid Services, you must abide by their rules. And CMS, in my opinion, has been, when I say on fire, as the kids say, because they are like really ahead of the game and they're giving requirements that are applicable. But having said that, the area of opportunity is that, or the sensitivity is, given the fact that there's a nationwide staffing crisis, you've gone through a lot. So in my Thoughtful Thursday, I'm trying to give you information to help you, knowing how much time it takes myself and the Harmony team to prepare information. And you might just walk away from this 60 minutes going, hey, great. I now know that these trainings need to occur. Now, the concept is that you are providing staff the tools to be successful in their job. The other overarching theme with these training requirements comes down to your facility assessment. And any of you that are monthly clients of Harmony, you know that we hyper-focus, or we should hyper-focus on your facility assessment, because that is what you hand to the surveyors when they come in to do your health inspection. The overarching theme of education and training is that the facility assessment defines who you are as a facility, and the appropriate training should apply to the staff. And these staffing requirements are not just for direct care staff. They apply to consultants, volunteers, and non-direct care staff. And the overarching theme with regards to education and training is that you have a curriculum. You have a curriculum, and you are not just saying, hey, you're going to sit in the room and listen and get your CEUs. I'll answer the questions at the end. Thank you for that, chat. That they're learning something. And as I develop and refine all of these, there will be an associated quiz. And because why? It's not about just being there. It's about being there, understanding it, and applying it. So, number 1, the first thing that you need to know is today is week 1, and we're doing the overview. But then there'll be 7 more weeks, and the first area we'll talk about is communication training. I'm going to do an overview today. The next week, we're going to talk about resident rights. Number 4, QAPI. Number 5, infection prevention, infection control. 6, compliance and ethics. 7, in-service training for nurse aides. And 8, behavioral health training. So we are speaking about the education requirements that you must train all of your employees by on or about October 24th of this year. And the goal is that A, you know that you need to do it. B, you establish a system to do it. You have the curriculum and you have the sign-in sheets and the tracking. So when the surveyors show up, you can prove and show. And they have other ways to determine if you have successfully completed this, which we'll get into. So the training requirements, to reiterate, develop, implement, and maintain. I will say to you that what I do for a living, and it's extensive, and it takes a lot of time to read the regulations, and then, as I say, distill and synthesize them in order to give you the information. Now, I bring this up because I also have a PowerPoint, which I haven't shared with you yet, on the actual ROP, not the training pieces. The ROP PowerPoint is almost 500 slides. I say that not to stress you out. I say that because it takes me 8 hours to explain to someone what you need to do in order to meet the requirements. So if it takes 8 hours just to explain it, then execution is going to take a long time. But why? We have to be organized and efficient, and there are certain things that you can do to get the job done. So develop. So you need to develop. Well, hopefully I'm going to do 80% of that for you and develop the content. Now, being mindful that your development, okay, has to be specific technically to your facility assessment, because the whole point of the facility assessment is to define who you are. So if you, in your facility assessment, state this 126 bed facility has a primary orthopedic population with an average length of stay of 21.3 days, and their discharge destination is to home, and we have 25% of cognitive impairment. The idea here is that you know that you have an orthopedic population, and you're going to train your staff on what are the risks and what are the approaches that need to be applied to provide that patient resident with the optimal care for their stay. Okay, they are at risk for hip dislodgement if they, and I always use this one, I don't have shorts on today, but if they don't go beyond 90, they can't lift their shoe up to tie it, nor can they bend. Well, if you defined in your facility assessment that you have that type of patient population, then CMS is going to expect that everyone in the building knows that your orthopedic population has hip precautions. And from the receptionist, right, to the maintenance, to the housekeeper, we all know. So you're developing something that is specific to you, but there are many, many programs out there that may apply that are already created. And so if you define yourself as having a cognitively impaired and there may be dementia, the rules of engagement would be that people need to be trained on how to approach the dementia patient or the TBI, the traumatic brain injured patient. So for example, we would not go up to a traumatic brain injured patient and touch them on the back, right, if they're walking down the hall, because that's going to alarm them. And there's just rules of engagement in that level. So develop, implement, and maintain. So here's the curriculum, and it's what we have and what we're offering consistently to all of our employees. And we are created it, we're going to implement it, we are going to give it on hire date, and we are also expected to revise it because things change, and that probably is a big piece of this as well, and maintain. And the expectation here is that there is an associated competency. So all of the Harmony competencies have the quiz, because that's what we applied 4 years ago, meaning we have that application because that's what the regulations said to do. And the maintaining it is that, okay, systematically, who's tracking this? Do you have a staff development coordinator? Do you have a regional person? Do you have an outside company? Many, many ways that you can implement this. And it's an effective training program that is based on your facility assessment. But hear me out. When we talk about these 7 areas, we've got communication, resident rights, we have the QAPI program, infection control, compliance and ethics, in-service training, specific, and behavioral health, which goes there. Those are not necessarily so specific. The specific ones are, with regards to CNA training and what would be in your general population. Now, I've said this to you before, and I have to reiterate it. When you develop your facility assessment, you all know viscerally what your patient population is. You just know. But trust me, my whole career has been in the medical record. What is in the medical record may not be exactly what you think is going to be spit out on an MDS or when you're summarizing your patient population. So take a good hard look at ensuring that what your diagnoses are in the medical records is actually what is there. That's called also sequencing of diagnoses. Your focus on sequencing of diagnoses has been heightened because of the advent of PDPM, but prior to PDPM in that RUG system, you may have been less focused on it. So this is another reason for that importance of that accuracy. So who is the training? So the tag is F940, and it must be completed for all new staff, your existing staff, contracted individuals, and volunteers. And again, but look here, it's the training, the amount and type of training required should be reflective of the services that you render, patient acuity that is identified, depicted in your facility assessment. So everything goes back to this facility assessment. And I am going to bring in the first sort of phase 3, 2017, because I think it's appropriate to talk about areas that you may honestly have not even gotten to. And don't forget about these are the tags that specifically need education, abuse, neglect, and exploitation, the required in-service training, and training for feeding assistants. That's coming off of the fact that you cannot use a CNA as a feeding assistant unless they have been trained as a feeding assistant. And that was what the origin of that. So we'll be talking about, this is back in 2019, 2017, just refreshing your memory a little bit, because maybe you implemented, maybe you did not, but now today moving forward, you have the ability to bring it all home and just get your curriculum all set. So we have the training, the communication, and resident rights. Resident rights is a big one, and there's a lot in there on the resident rights, and I'll give you that. So these are the areas. Communication. Why are they actually asking you to train people on communication? Well, because if you cannot effectively communicate with one another, you will not be able to alert or identify changes in a resident's functional status and effectively care for that resident. The communication also is a product of technology, and the technology gives you different modes of communication, whether it be a chat, whether it be an email. But the key aspects of the communication is that you ensure that you have taught individuals within the organization what the rules of engagement are with communicating. You have policies, you have procedures and protocols for that. The resident rights, and listen, I know that you all, that is a standard for you. Resident rights has been refined, and this also will go into person-centered care, which person-centered care, yes, it's under technically resident rights, but it really falls under behavioral health. So we'll get into that as well. And then QAPI, and QAPI is one of my favorite things. And we talk about QAPI plan of correction in QAPIing it, but the focus on this QAPI is that everyone in the building knows what QAPI is, everyone in the building knows what your initiatives are, and everyone is enlightened and they understand it. In the context of non-training requirements, the detail that the ROP gets into is, how did you figure out what metric you were using for QAPI? What calculation are you using for rehospitalizations? Meaning every year they're getting better and better because they're expecting that you're becoming more refined with the implementation of their expectations. Compliance and ethics is, listen, there are 7 elements. We will go through them, understanding what needs to happen for a compliance and ethics program. I get it. I understand that this is one more thing. If done correctly, if follow the rules, it will, I promise you, it will make your organization better, and I promise you it will make your operations easier. Behavioral health, we'll get into that with person-centered care, SUDs, substance use disorder, so many positive things that the government has taken that scarlet letter away from anyone that has a DSM-5 and basically putting together the physical, mental, and psychosocial well-being. Abuse and neglect, again, this falls under the resident rights in the context. This specific one is, all about the patient's voice, giving them control over their environment and ensuring that they or their representative has the ability to articulate their needs, and they're very aware of their medical care. So in-service training for nurse aides, there is basic, but then there'll be refinements depending on your patient population, and then the training for the feeding assistants. So the one important thing that you should do is you should cross-reference those 7 areas and see if they are part of your onboarding and your annual competencies. And the annual competencies, like I said, Harmony, obviously, we've been doing this for 21 years. And when they talk about, and again, this is refined, they're saying, hey, what are your objectives? What are your goals? What do you specifically? It is a process for refining your educational. They are expecting that you have a mandatory re-education plan. And I will say this to you, I am a life learner. So if you think that you're going to get it all in one sitting, you're not. And things change. But the annual mandatory re-education plan is saying, hey, I'm going to make sure that the staff that work for this organization are apprised and on the cutting edge of the changes. For example, when I gave you that example of the femoral head popping out the ORIF of the hip because they bent down to tie their shoe, actually no longer applies, because when they are doing the surgeries now, they do some anterior ORIF and it does not require the hip precaution. So that would be an example of being current with the information. The other part of this too is technology is a massive assistance in the speed of technology, but it can also be a negative. In other words, if you send me an email in the last 2 days, I've got 700 emails, I'll use the weekend to catch up. But don't have that false sense of you hit send, the 500 slide PowerPoint goes in the air to the employees and bam, you've taught them. It's not how it works. You see, you can only retain 15 minutes on the hour. So you can't possibly hear everything. So therefore, the re-education plan is to make sure that you're consistently giving the information to the staff, and 2, that you are updating it to be current. Now, again, I know some of you have seen me speak a lot, but one of the areas is that, well, it can cost money and it's time. And I'm going to give you the quote from one of the books that the CEO says, we need to train everyone. And then the CFO says, well, that's going to cost us a lot of money. What if we train them and they leave? And then the CEO says, what if we don't train them and they stay? Right? So, hello. So it's all about, the information. And so there are noteworthy changes in the ROP from 6/29/22. And we will highlight those changes, even though there are a lot of basics that many may not be aware of, okay? So there is new guidance throughout the majority. One thing that you should note for the compliance and ethics, that the annual training requirement is for organizations with 5 or more facilities. But again, with compliance, in my opinion, it can take upwards of 3 years to roll it out and effectively put it in place. And that's consistent with if anyone's ever been under a corporate integrity agreement, the government, the OIG is in there for 5 years because it takes that long to roll it out and apply it. So we're going to just go through that. So a little bit of a reset here. We've already talked about this. Who are you training? Everyone. Now, communication. So the specifics, and we're doing communication next week. I am going in the order of the FTAG. And this is specific for direct care staff because it's about teaching them how to communicate, when to communicate, and the aspects of how to share information, understanding that the root of this is patient care driven. If I observe that the patient has the beginning stages of a contracture, or that maybe they're drooling a little bit, or something that could be a major issue, it's sharing the information with the team so the team can address it. That's the root of communication. But with the advent of technology, and I talk about this all the time, the ability for me to have an impromptu discussion with someone. I go up to the nurse's station, and this is going to age me, of course, and say, oh, can I see Charlie Brown's chart? They hand me Charlie Brown's chart, and then they say, oh, the doctor is in. He's going to need it in 5 minutes. Oh, excellent. I do need to ask the doctor if it's touchdown weight bearing, or can I do weight bearing as tolerated? And the actual handing of the record, right, promotes discussion. Well, you now have this wonderful technology. I can sit in my home office and talk to you, and well, I can look at medical records, right? Well, that also decreases my ability to have impromptu discussions, and resulting in potentially less information sharing on very important subject matters regards to the patients. So that's the essence of this, because you have to know why before you can do it, and why their responsibility, right? And any changes of conditions, and that they're going to have, where are they going to put that? Where do you write it? Do you have a sit-down meeting every morning? Do you have an end of the day meeting with your staff? Do you have a Cardex? Do you have, what mechanisms do you use? Because I also will tell you that the technology giveth and taketh. And the taketh is that there are fundamental principles that have been omitted and missed in the world of healthcare for some reason, because it just got missed in the transition to technology, like the admit to skilled order. And this effective communication is also not just verbal communication, it also extends to body language, verbal cues and nonverbal cues, and assessment and active listening, which is a massive opportunity for everyone, right? Active listening is painful for those that talk a lot. And if you're not listening actively, then you're wasting everyone's time, because you're thinking about what you're going to say, right? Instead of assimilating. And it's a learned behavior to be mindful that you are actively listening to what someone's saying without letting your mind go off, right? And that competency comes in understanding, comprehending, and everyone has different learning structure, and adults learn differently than children. So you want to ensure that the training of effective communication is understood, that it's not a monologue, not what I'm doing right now. This is a monologue. It's a dialogue, and that individuals listen, engage, and apply, and they understand what the resident or the other staff person or other employee has or requested. And the observation, and again, the nurses, the therapists, the healthcare individuals were trained on this observation in school. I mean, there's many, many reasons why clinical practices and co-ops and all that occur, but it's observing the verbal cues. And you know how I talk about my verbal cues, right? Tell a joke, or someone tells a joke and you laugh. The first person you look at after the joke is the one you love the most. When you walk into a room where your feet are pointing is the person you want to talk to most. So body language has a massive, play in here. And it's also in the context of patient-centered care. And patient-centered care, meaning it's about the patient, not about your operations, but the CNA, the nurse, it's eye contact, it's smiling, it's nodding, it's not looking at your phone or, writing at the same time. It is being in the moment. So these areas, and yes, the surveyor can look at your documentation and see that you have the tracking log. Great, you're winning. But also, it's not that is not the only thing they'll be looking at. They will be looking at observation of staff resident interactions. So have I ever done a presentation without bringing an OBRA 87? No. So the goal is that the direct care staff, they're providing care and services to allow the residents to what? Attain or maintain their highest practical state of physical, mental, and psychosocial well-being. It's your job to make sure that everyone around that resident is giving them an environment and for them to excel. So this is the number one goal, and that you're over 87 for those that do not know. And that just reminds you that your communication should reflect the resident population. So for example, there are homes for the deaf, right? So sign language would probably be a top priority for care providers in that setting to learn. So be mindful of that. So I've got extra stuff in here that I might just, we will get into the communication specifics next week, but a little preview of, understanding your role as a contributor to an engagement, understanding, the placating words or words that are going to be volatile. And again, it's all about, this plays directly into person-centered care, and having that information will be critical. So, okay. And okay, we already talked about that. Great. So that's number one, communication. Week 2, communication. Now we're going to go to week 3, which is resident rights. And this applies to all staff, not just direct care staff. And the resident rights, which every new employee, I'm sure you've trained, but you see, the point is that it's your responsibility to make sure that everyone's educated so that they know the rules for the interactions for the residents. And the importance of these resident rights is take your over 87, attain, maintain physical, mental, and psychosocial well-being. It's also the dignity and respect, treating patients with dignity and respect with any interaction, from the housekeeper to the CNA to social service, right? maintenance, anyone that's having this interaction, and you want to make sure that you're enhancing their self-worth, their feeling of efficacy, and that you're being respectful, and you are very respectful and mindful of their individuality, which also will play into the person-centered care. I was in California a couple of weeks ago, and I saw a phenomenal presentation on gender and LGBTQ and the emergence of, like, if you have to think about this, if someone has been out of the closet and all of a sudden they're now going into an institution, they may go back in the closet, which is a very sad place for them. Meaning, so that I never thought of this, never thought about it. And understanding their individuality and giving them this environment and ensuring that your care plan incorporates the goals, their preferences, their choices. It's specific to the individual. It's not how you think it should be done, it's there. So this takes patience, takes active listening. What's going on, right? Tell me about you. And really rolling that out. The curriculum should be accurately defined. In other words, looking at what you expect the curriculum to be and rolling that out, which will be refined every year, but I'm sure your basics will be there. Now, right here, again, we've said this ongoing education, right? The caring of the patients, the residents. Current scope and standard practice, meaning the hip fracture I'll use. Oh, we don't have to worry about hip precautions anymore because there's a new procedure for anterior ORFs. Excellent. What is the current scopes of practice? And every single session that you provide for education, what are the learning objectives? What are your expectations for performance? And what is your evaluation criterion? In other words, how do you determine that that individual assimilated and understood it? Is there a practical application component? Is there an observation component? And understand. So again, always an ongoing. The other part of it too is that with regards to the information, it's information overload. So also incorporating, I'm all about like signs and visuals or motivational type things. And it could be that in your weekly employee newsletter that you have a reminder, whether it's via email, maybe it's on paper, I don't know, maybe it's an app, but it's that constant familiarity with the rules. So how do the surveyors, and by the way, that's this whole key here. When we know that there's new guidance, realize that we know there's new guidance because it came out for the surveyors. So we look at that guidance and we say, okay, this is what they're hyper-focusing on, because you've got your state surveyors, but realize they're underneath the federal CMS. And so again, what are they being asked to do? Have they been trained? What did they say to them? And if you've seen it, you must, it's a zip file and it just was updated yet again. It's about this thick if you print it out, but there are paths for every single tag and it coaches the surveyors on what to look at. Meaning in this particular situation, I would interview these people, or you need to walk through the floor and you observe, or you do a record review. So you know that the information is going to be garnered through interviewing people, their own observation, and going into the medical record, which all three can provide a font of information. And they're ultimately looking for to see, do the staff in your organization comprehend what the resident rights are, right? And furthermore, your responsibility. It's your responsibility to ensure that they have visitation at a certain time. It is your responsibility to explain to them, to the resident, by the way, you know that your daughter can come in, right? In other words, I know that we gave you the resident rights on admission and you and your representative signed it, but that was a lot of information coming at you. So just so you know, you were allowed to do that. So it's not a one and done type thing. oh, here are your rules. Oh, thanks for signing that piece of paper, right? Doesn't work like that. And we are hyper focused on person-centered, and this information, okay, quality of life, when we do resident rights in that area, I am going to bring a lot of quality of life stuff in there, because it's a reminder to you of the changes that happened in phase 2. And because it's been a while, so we are going to go back to basics on that as well. And the other area that's important is that, as I said earlier, the changes in technology are something that have spurred this. And I have to tell you that if I do this grade 8 every year, and it's the top 8 things, and it's like 50, but no one knows, but it's 8 things that you need to know. And I had read 8 years ago, maybe 6 years ago, that it takes 100 years to double your intellect. In 6 years, it's going to take 20 minutes to double your intellect. Now, this is like I said, 6 years ago. And I remember putting it into the grade 8 and talking about it. But in my head, I'm like, man, how is that going to happen? Well, I figured it out. TikTok. You laugh. But you see, those people that do TikTok, they have to distill and synthesize. Like, you want to go learn how to bake something, not me, but bake or cook. They take it and they chunk it, right? Not chunk it, they snippet it. So how is it possible that we could get information and double our intellect in 20 minutes? It's because of technology. It's because of, we're Zooming right now, and you have that information. You can, obviously get the regulations on the governmental website. You have access to this information. It giveth and it taketh. You can get it if you know where to get it concisely, efficiently, and effectively. But it also can be a rabbit hole. You can go down that hole and you're looking for something, and 5 hours later, you're baking a cake. So the David Wright runs the sector of the surveyors, okay? And he has said, we at the clinical practice committee, he comes in and he knows that the states want inter-rater reliability, that we want all states to have the same process, because why do some states have higher CMPs than others? And it's good that the government has refined it, because they're saying, look, we want to make sure that our interpretive guidance, how the surveyors are taught, right, has clarity. They give solid examples and directions on what is compliant and what is non-compliant. I believe that's a good thing. So in the context of resident rights, again, you want to maybe commit them to memory that, your resident representative, it's either you or the resident or the representative, that's the person that is representing them, okay? But they have to make sure that they're in the legal bounds. So the government's saying to you that there are rules, but you also have to make sure that the people around you are following the rules. And that legal representative is not overstepping their bounds. Participating in planning of care. I don't know where I was in the last quarter, but it's all about inviting the resident and the representative to the care plan meetings. That is a given. I mean, I've actually stumbled upon some areas in which this was not happening. And choice is a big word you're going to see here, because choice and control of your environment is very important, especially when we talk about person-centered care and SUDs and behavioral health. Someone who's had an incident and is in PTSD, control. So a choice of who your physician is, right? Control of your environment. Visitation. Now, I haven't had the party in my brain yet, because in September of 2021, a year ago, out of the blue, and maybe it wasn't out of the blue, but there was this whole thing on visitation. We had just gone through a pandemic. People were not allowed. And I did ponder it going, I'm shocked that they're not allowed in, but hear me out. I understand. I'm not judging. Visitation, we had that memorandum come out in September of 2021. It was a game changer, right? So visitation is a big deal. It's a big deal when, why, who, how. The patient has a right to refuse treatment. They have a right to request treatment. They have their advanced directives. Grievances will be a big one, and the reporting of the grievances as well. And external entities, what does that mean? Oh, that the resident has access to speak to ombudsmen, state, feds, that they have access to entities beyond your organization for them to communicate to. And then a little asterisk on the res rep because it was previously a different number. I just sometimes pull that out. There is a crosswalk, but still, for those of us that like numbers. And as you can see, the representative acts within their legal responsibility. They don't go out, they don't color outside the lines. They don't do things that are not in their scope. So, and I will get, we do resident rights, I'll get into it detail. I definitely may skip over some of this stuff. There is going to be a new PowerPoint for each week. So the understanding of the resident's delegation of rights has been followed. That's what a surveyor is looking at. Did y'all do the right thing by this guy? You know, it's one of those. Okay. And if they have a designation of a resident representative. So the participation in care planning, it's a must. In other words, including them, they have to vocalize and verbalize. And I'm going to skip through from it because again, we got 15 minutes. Choice of attending physician, great. Visitation, the equal visitation privileges, meaning that it's consistent and not biased. And if there is a restriction because the patient is sick or they have some contagion disease or something, that you have thoroughly expressed to them what if they can or they cannot, and if they do, what the ramifications would be. It's all about the documentation that you've expressed this. So, okay, visitation. They're going to always support the visitation. Policies and procedures. We do have to have a lot of conversations about policies and procedures, and I get it. I get it. You got them on the back shelf and they're all there, and you know, sometimes you're operationally, you just do it without them, and sometimes you need them to do it. But you're better off not having the policy versus having one that you do not follow. The policies and procedures have to be definitely specific to you. Yes, it's very easy to get a cookie cutter, but sometimes it's just more work. But taking your basis and your culture and ensuring that you are revising them specific to the changes that came with the ROP and the resident preferences. I am going to skip over that. The refused treatment, advanced directives. Okay, very good. Grievances are a big one. That grievances, allegations, and your ability to respond. So in that context, it's important for you to be able to have a procedure, a training on what should happen. It's a high focus. So, as said earlier, their ability to communicate freely with feds, state, or local representatives. Okay, now we're going to jump into QAPI. So QAPI is week 4. So I'm just giving you the overview of what the trainings will incur. You may be sitting there taking notes going, okay, I got it. I understand what I have to do now. So QAPI. Now, the QAPI program, I'm going to say this to you. Every time, if you get tagged on your survey, QAPI it and include it in your plan of correction. Quality assurance, performance improvement. QAPI is the essence of you proactively identifying areas that you would like to bring in a group of differing individuals to see if you can do it better. QAPI is not a reactive type of thing, it's a proactive. However, you may QAPI reactively because you have no choice. And The facility should know what the definition of QAPI is. Dr. Deming is an electrical engineer who created this concept and he specifically used it in the automotive assembly lines. He's an American who was shunned by businesses because he focused on quality over quantity, i.e. profits. And he was kicked out of the United States and went over to Japan, and he perfected the assembly line for a car manufacturing. How many of you drive a Toyota? And his practice, the concept of QAPI is that you have a data-driven system. In other words, or I'm going to look at hospital readmissions. My hospital readmission is 25%. I'm going to calculate it the same way. And I'm taking this group and I'm putting them together because we want to see what we can find that will decrease our hospital readmissions. We don't know what the contributing factors are. We want to be open-minded. As we identify, we are going to consistently track the number part is the hospital readmissions. And if the hospital readmissions goes from 25% to 15% to 5%, it goes down, one can assume that the application of the steps is working. The concept is data-driven, interdisciplinary, looking at areas that could impact it. We will do a case study when I do QAPI. That's part of the QAPI training. So the other piece is that it should be knowledge that it behooves you to communicate to your staff what you're QAPIing, because they may not be on the committee, but they may have information. I'm going to give you a very simple one, but maybe you're QAPIing falls, and all of a sudden housekeeping says, we are using a new floor waxing machine. Maybe there is a correlation. I don't know. So gaining information. The mandatory training for QAPI, and the getting, I said earlier, they're going to get into the specifics when they come in. How did you determine the metric? How did you determine how did you determine the calculation? It says that in the ROP. Details. How are staff in your organization able to communicate what they think is a concern? And the grade 8, I always end it with the leadership strategies and tips. If the day the soldiers stop coming to you complaining is the day that you stop leading. So when you don't hear the complaint, you're not going to have the information. And every leader knows that decision-making is a skill set, and decision-making is based on the information that you receive, because you cannot be everywhere. So once you stop getting information, you will no longer be able to make the best decisions. So QAPI, teaching what is QAPI, when do you do it, how do you do it? How does a staff member say, hey, I think you should QAPI food satisfaction? Something. Why do you say that? Maybe active listening. Why do you say that? Now, fun fact, you can be cited, okay? And you could be tagged for deficient training, even though you do not have a tag in that scope. Do you follow what I'm saying? So be mindful of that. You could be cited for having a training deficit without a tag in that domain. Fun fact. Of course, with all of these, this is not specific to QAPI. It's all about your staff, the tracking of the staff participation. And whether it's sign-in sheets, whether it's someone else, you could do screenshots. There's so many ways to do it, but the screenshots. Okay. And the elements of the QAPI, et cetera. And all of this we will get into when we do the QAPI piece. So infection control. Infection control is week 5. It's number 4. And infection control what can I say about infection control training is that, well, every week we get new information, and the most recent information has to do with masks. And it just came out, I think, a week ago that if I visit someone in the facility and I have no symptoms, I can take my mask off, I can hug the resident as long as the resident's roommate is not in the room. So you have to be mindful of that. And this is the hard part. Things are changing fast, and obviously because of the pandemic, but you have your P&Ps, you have your standard P&Ps, droplet, contact precautions, all of that. And just making sure that everyone is trained on infection prevention, everyone. And again, I'm all about that 20-80% principle. What is the #1 infection control tag across the country? Hand washing. So where would I start? Hand washing and observation of hand washing, meaning your walkthroughs, because if it's the #1 cited tag, I'm telling you it is, that you know what they're looking for. So where would I begin? Hand washing. Yes, donning and doffing and clean versus dirty, and before walking in, we'll get into that. But the 101 is, what are my precautions? How do I prevent spread? How do I track it? What do I do, right? It's the environment, the clean, infection control. So again, to get a little deeper, and the infection preventionists in their role, they are obviously looking at the community, the national standards, staff turnover, the physical assessment of the environment, the facility assessment, and it's constant. And that just goes and plays into the whole QAPI. It is ongoing. It is define what makes you successful facility assessment. Refine is QAPI. You're always trying to do better. I give the example, and I don't know who this guy was because I can't remember his name, but some guy called me 4 months ago, and I said, how'd you do in your last survey? And he said, we did great. We had 0 deficiencies. I said, that's amazing. He goes, they just didn't look in the right charts. And I'm like, what? And then I thought about it, because they just didn't, meaning, yeah, we did great. But I know that there's always room for improvement, because that's the business we're in. We're in a service industry. There's always opportunity to be better. I'm not going to be so arrogant that everything's great here. No, there's always opportunity for improvement. So that's the concept of that. But every one of these, we're talking about the learning objectives, the performance standards, the evaluation. What are the risks, right? What are the risks if they do not understand or they're not trained? The risks are spread of infection. The risks are staff illness. The risks associated with not completing these trainings is real. So again, what are the surveyors going to do? They're going to look at your logs. They're going to look at your training logs. They're going to observe staff. They're going to interview staff. You should be training your staff on being prepared for when they come in. They have to be audible ready. They have to be audible ready to know. And that's why I say this constant reinforcement of, prevent, mitigate, identify, deter. Identification in a QAPI program, in a compliance program, is a key word, that you have the ability to identify. Oh, I have to identify in my plan of correction when I have a citation. How can I prevent this from happening again? You have to have the ability to identify it, or the risk of it occurring. So they're going to come in and they're going to be looking at to see what you're doing for your infection prevention. So compliance and ethics. Compliance and ethics. There are 7 components of an effective compliance program. And I will say that each one of those 7 elements is a 3-hour, I mean, if you're talking competent, you're talking certification, it's a 3-hour course. And so an example of one component is policy and procedure. It's the first one I talk about. In order to have an effective compliance program, you have to have policies and procedures, but there's one policy and procedure that you must have. Well, what is that, Chris? You must have a non-retaliatory P&P. Well, why is that? Well, because in order to have an effective compliance program, guess what? The complaint has to come to you. The complaint is the gift. So now the complaint comes to me, but if I don't like the complaint, quid pro quo, I don't want to, you're fired. That's why you need a policy and procedure that says, please come to me with your complaints and your feedback. And I promise you, we have a policy and procedure on here that says we will not retaliate. We want that information. So it's about, okay, this is the application of the compliance program. So in, let's see, week 6, we will go over the 7 elements. And that's a great one to have people sit in and listen to get their training. So those 7 elements. And the compliance program, FYI, the rules were in the Federal Register in the year 2000. Okay, the off, it was 2001, but it was never mandatory. It was always recommended. And then they came out and said, okay, it's now nurse aid training. And nurse aid training is, we talked about this, that it's the expectation that there is a program that they receive the education on the components of being a CNA, and expanded. There's a 12-hour nurse aid training in addition to the competencies for dementia, abuse, and doing performance reviews. One of the things that I think is helpful is when you have a buddy system and you have a tiered CNA structure, CNA 1, CNA 2, CNA 3, because when I was doing infection control audits a couple of years ago during the pandemic, I was doing buildings within the same bigger organization. And what I uncovered was, like, this is the same management. This is the same like infrastructure. Why is it so different in this other building? Not that that's not uncommon, but because in one of the buildings, the senior CNAs retired because of the pandemic. And you may like, okay, so what? Well, you see, senior CNAs are more apt to coach, mentor. Hey, wash your hands, sweetie, right? That hierarchy, that level will help with peer coaching. So, you know, it's like I'm 55, so now like I'll do a sales call, meaning someone's trying to sell me something, and maybe I don't buy it, but it's some 24-year-old, 26-year-old. I'm like, great job, sweetie, you did a great job. You know, I'm not going to buy from you, but great job. But it's the coaching of it. It's that mentoring, because when you have an academic sit-down class of, okay, I have 7 trainings that I need to do. Okay, knowing it and applying it are 2 separate things. So it's, we're going to give you the classroom style, but now let's see how you do. That is massive. So again, if there's the ability to do that, and we'll go there. Okay, so I'm running out of time, and you know, abuse. Now we'll get there because we're going to get there with behavioral. Now under behavioral, a lot falls into here. Okay, we've got the comprehensive person-centered care plan, right? It's about me and my schedule and not you. Yep, I know you serve food from 6 a.m. to 8 a.m. and then 12 to 2. And no. You see, I'm going to eat. I'm going to drink my juices, and I'm going to do it my way, because the baby boomers are coming in here. They're merging right in, and they are the biggest population, the biggest demographic. They set the path. And it's understanding that, okay, how are you going to meet all of this? You're going to meet because you have to train the people on, it's about what they want. This all falls into active listening. Identifying what is it that you like? We talk about the Ritz-Carlton in the service industry. And here we go. So person-centered, right? Understand, they have control over their lives, right? You and your team are gonna support it. And their resident is the locus of control, making the decisions, attending care planning meeting. They have a voice at the table. You never want to take away the voice of the resident. Why is control so important? Especially, and we'll get into this, trauma-based care. Trauma-based care meaning, oh, you have been traumatized. If someone has been traumatized, then they have triggers and there are means in which to mitigate those exacerbations. Let me just put this a different way. And the person-centered care plan, we're talking about it being resident-centric, patient-centric. In fact, person-centric. You shouldn't even put the word resident or patient, because you do not want to even have the image that it's a patient, it's a person. So again, what are their preferences? They have to be in the know of, can you go home? Do you want to go home? What are your goals? What would you like to do? Okay, I understand you got the 5 kids out there and they're fighting over there, but what is it that you want? Because I can help you with you, right? And making sure that you're bringing all that into consideration for it. The behavioral trial, again, I commend them on this because you see, behavioral health was a scarlet letter. Oh, they've got depression. Oh, they've got anxiety. Okay, well, first of all, those fall under the DSM-5, a DSM-5 Diagnostic Statistical Manual. And it means that these areas, okay, they include schizophrenia, they include anxiety, depression, bipolar, ADHD, autism. And these DSM-5s or mental health issues would be stigmatized, the scarlet letter of, oh, they got something wrong with them, right? But you see, there's been an enlightenment here that, oh, well, wait a minute. Mental health issue is equally, if not worse, than a physical issue, and it's the mind, body, and soul. So identifying the DSM-5, which for those of you sitting here today, 5 out of 10 United States individuals will have a DSM-5 in their lifetime, meaning that, and those are the ones that went to the doctors. So let's just make it 6, 7 out of 10. I have a DSM-5, I have ADHD, didn't know I had it until the kids got diagnosed 4 or 5 years ago. So, okay, well, why is that so important? The reason that's important is because if someone has a DSM-5, statistically, they will have difficulty with relationships, which means when they get sick and they go into the nursing facility, they might have less support. And in order for it, you need support when you're sick. So it's one of the metrics that they look at. But also, relates to the fact that the staff need to be trained on the DSM-5s and understanding, oh, that someone has this issue and wait a minute, they have a trauma disorder and they are in PTSD or they have PTSD. You need to know, A, that they have it and what triggers it. So in other words, it could be a song, it could be a smell, it could be something. It could be, it could be the mere fact that you're institutionalized, and that's the word they use, is a trigger. So let me just say this a little bit differently, okay? Everyone has a potential of having a DSM-5. The way that you don't get a DSM-5 clinically is that you have established coping mechanisms in your life. So for example, you run every day, you walk, you watch Netflix, you drink a glass of wine, you drink a liter of vodka. Don't know, don't care. I mean, I care, but I'm not judging. Don't know, don't judge. When the resident comes in, it's not like they're drinking a liter of vodka every day. That's not person-centered care. It is about, oh, okay, so tell me your story. What's going on here? Because you see, they're drinking a liter of vodka to prevent the DSM-5. So it's their coping mechanism. So in other words, people will have things they do. My coping mechanism is Netflix, right? But yours could be yoga, it could be walking. If they don't have a coping mechanism, they are at risk of having a DSM-5. This leads into the trauma-based care. People that have had trauma will also have a potential for DSM-5 because again, it's the body protecting the body. So, but they could be functioning for years, but in the care plan realm here, it's your awareness that someone could come in. Now again, the vets have this nailed down. They get it. They know how to do this. They identify the fact that, oh, the situation arises, they have this anxiety, this issue. And now one other thing I'm going to tell you about this, and this is a true story. So I was called into a client and there was an alleged sexual assault. And the team was in before me, my team, and said, you know that they are hyper focused on the fact that it didn't happen. I said, gotcha, go in there. And the first thing, and they were right, they were hyper focused. And I said, listen, I open up the door of the barn. I look down and I see a snake. Whoop, fight or flight, pupils dilate, heart rate goes up, bead of sweat goes down. My body reacts. I look down, it's a rolled up piece of rope. Did that negate my fight or flight molecular level experience? No. So if the resident perceives that this occurred, it's irrelevant if it did. Immediately, let's train everyone on trauma-based care. So what do? Care plan. What is it that you need? Do you need your own room? Do you know male will help dress, bathe, caregiver? We're going on the elevator. Do you want to go on that elevator alone? Because what do? You give them control. Give them control over their environment. Now, there is no doubt that this individual may have had an occurrence and been assaulted in a prior life, like prior to this. This patient, of this situation, 4 months afterwards, it was determined that it did not happen in the facility, it happened in the hospital. But the point is that staff need to be trained on how did the resident feel? So this area, and I'm almost done, and I'll look at the questions. It's going to talk about knowing the resident's goals, the patient's goals, interpersonal communication, doing meaningful activities. Again, what did you do with your life? What did you do before, right? And that you are providing them with an environment and an atmosphere that is conducive to mental and psychosocial well-being. It's not the TV blaring in the lunchroom, right? Noise, sound, light, all of those things that have to be addressed. And you are going to go in with non-pharmacological approaches, and you're going to go with specific needs. And, depending on your facility assessment, defining who you are, you're going to have treatments that are applicable to that. So I'm going to look at the Q&A. Let's see. Okay, can the education be in webinar format? Yes, it can be. And so you can do the education. Now, it's interesting because, so the CEU part, whether it applies, is important to you or not. So in other words, so everyone's asking about this presentation here too, but when you get CEUs for administrators, it's through like NAB, and then you have nursing CEUs, which we're a provider of them. So whether it's a webinar, whether it's on demand or in person, the nursing CEUs are there. I know you're asking about RRP. With the administrators, whether it's live or on demand, it depends if it's nabbed. Now I'm saying that. So your question is, so my goal is that helping you guys by developing what's specific to you so that it can be a recording, but that recording can be played over and over for your staff, because it is very difficult. Look at, it's so difficult right now for you to even pull people out to be trained. So I like the hour snippets. I love the boot camps because it's palatable and it's feasible that someone could jump out for an hour versus 3 days. So yes, those trainings do not need to be in person, but you must have a tracking mechanism. And that's why it's so important to have a post quiz that, and we do all of us on SurveyMonkey, and it's great. And so therefore, like someone will say, oh, can I get my CUs? And then the team will say, well, you didn't take the test. So the quiz. So yes, they do not have to be live. So let's see. Give me a second, I'm looking through these. Okay, so, oh, what kind of juices do I drink? All right, so they're pressed juices. Okay, the slides. The slides, I haven't even gotten that far. And what I mean by that is typically what happens is that I will record this, which I did, and then usually I'll offer it for you guys. Give me a couple of days. I might make it public and free. And because that's what I used to do too, and send out the slides to you guys. As long as, usually if you're here and I have you registered, that's important to me. So, and I'll talk to Asha and Polina. They're the piece of the media team at Harmony. But I do have to, this slide deck is functional. It's not perfect. So let me perfect it and I'll send it out to you, because that's what I'll do. Let's see what else. Okay, so everyone of you. Okay, someone says, this is cute. Has there been research at all if using social media such as TikTok, short YouTube videos is effective for education for nursing and nursing assistants, especially for the younger generations? Okay, great question. If there's been research on it or not, I don't know, but I do know that like YouTube or videos. So people, okay, give me a second. I believe that the education system should perform a neuropsych eval on every child. I'm an OT by background, and I missed the mark that my kids had ADHD. Well, you know why? Because if you have ADHD and you weren't diagnosed, it's very highly likely that you wouldn't. But why wouldn't the academic system do this eval? I'm going to answer your question, I promise. Because what a neuropsych eval does is it identifies anxiety and all these things. If the earlier you catch it, then what? Why I'm bringing that up is because you all learn differently. Some of you may say, oh, I just wasn't a good student, whatever. But I sit and talk to you and you retain everything that I say. That's because you're an auditory or a visual learner. Everybody has a different learning style. So you talk about TikTok and social media. I think it has brought, again, assuming that the information is real and academically correct. So I am sure that there is massive benefits to it, and especially with the younger generation. You want to know why? Because you see, our brains are wired. I still give out binders because of my age. I'm going to write to learn. But if you took notes and you typed, depending on how old you are, you may not have processed it in your brain. Interesting. So the youngest daughter, she's in the 9th grade, but I'm talking K through 8 was automated. iPads. As they evolved, they started to add the writing on the iPad. Again, Apple's got the edge there, right? So the point being that I do think there are components of it that can be very effective. It's Twitter on steroids. You understand, for someone to do a TikTok, or for me even to do this for you, you think, oh, she did, an hour and 6 minutes, right? But to write it, it could take me 8 hours because I'm distilling it and synthesizing it for you. So I believe that those mechanisms could be extremely valuable, right? To use the social media, especially with the younger generation, because again, if they flip through it, they can get that information. So, but again, it's all about knowing your learning style, and it's all about knowing your employees, because the employees, you'll see it. Again, why I bring the neuropsych eval is, don't assume that someone is not intelligent because they didn't learn it the way you taught it. It's important that there's like 3 sort of modes of it: education in a forum like this, but then there's the practical application on the floors, right? And then there's the actual doing in scenarios, right? So in other words, it's the case study, for example. So everyone learns differently. No one's going to learn it all in one swoop, but here's the best part. Always, the more you know, the less you know. You got that? Because it's happening so fast. You want to be around the people that are like, okay, great, I get that. But what if having that open-mindedness? I'm going to keep answering them. Do I have a TikTok channel? Okay, I do actually, and I can tell you what it is, and I will make it. And I was debating about doing TikToks. We're off the record here right now. I'm like, I should stop recording. But so fun fact, for those of you that want to stay on, TikTok, right? There are people that are famous on TikTok. Well, I have 4 daughters, and one of them, this is the best story. She has a TikTok. This is 4 years ago. And like, I don't know about it. Yeah, she gets 85,000 followers. I'm like, okay, like, you could do something with that. You could be an influencer, whatever. This is 4 years ago. I don't know. I just don't know if I like my demographic. You don't like your demographic? Well, what do you mean? She starts another TikTok to get another demographic. She has 35,000 followers. Who does that? So I've thought about it, because I'm like, okay, if I do a TikTok and I say, hey, you could quarantine, isolation, you can skill. I'm debating about it. What is my TikTok name? It's probably something, and I've never given it to anyone, but now I'm going to have to make it public. And maybe you're motivating me to do it. Let's see who I am. What is my name? It is Chris B. Harmony. Okay. And maybe I will do TikToks. Let's see. Anything else? I'm going to give you the slides, because I think there's 20 of you that have asked for the slide. I'm going to give you the slides, but I have to figure out how to do that, because there are hundreds of you on this. So I don't know. I have to talk to the media group, because they'll tell me how to get them to you. It's going to auto pop out. I'll figure it out though, but give me a couple of days. Let's see. If there's any other questions, you can always call me. My cell phone it's there. And I'm trying to think, let's see if I missed anyone. And you can use the slide. You can have the slides. It's fine. I'm going to send the slides out. And I think that's it, guys. So it's Thoughtful Thursday. I will see you next Thursday at 4 p.m. EST, and we are going to do communication, and I can't wait. Have a great day. Thank you.